thanks to Delvis and John and Louise for the invitation, the opportunity to come. It's one of my favorite meetings, and really has grown over the past few years, which is, I think, appropriate because the field has grown a lot. Treating lung cancer has become much more complicated, and by necessity, we need constant updates. We're going to talk about a couple rarer subtypes, RET and ROS1. These are my disclosures. When we think of these fusions in RET and ROS1, these are uncommon, these are rare, but they are important to identify when they're present. We pulled these numbers most recently from Caris, and so these represent next-gen sequencing results from a U.S. population. You see RET and ROS1 clocking in at about 1% of all non-squamous lung cancer. But as we've learned over the past few years and throughout the day today, that each slice on this pie represents a different biology. Really should be approached with different treatments, in some ways different cancers. And so as we focus on these particular subsets, how do you develop drugs for something that's so rare? How do you develop drugs for some targets that are so uncommon? Especially, we're not starting from scratch. We're really looking towards our previous success in EGFR and in ALK, as Dr. Lynn outlined. We're going to optimize broad testing. We're going to develop potent inhibitors, really make them more selective, understand resistance, and really stress that they work well in the brain. We're going to follow those same guidelines. We'll talk about RET and ROS1. Now, these two fusions are very different, but they're both more likely in people that haven't smoked. They both have a tropism to the CNS, high risk of brain metastases. And we also know that immunotherapy has been disappointing consistently in both these subsets. If we look at the immunotarget registry, a retrospective collection, which many people in the room participated in, this led by Julian Mazieres of Toulouse, we see that the immunotherapy pretty disappointing for these subsets. If we look at RET, the PFS only 2.1 months. It is very difficult to get a shorter PFS than 2.1 months. Progression, best response in most patients, 75% of RET, 83% in ROS1. It's not that they can't work, but it's likely that they won't. The response rates are too low. So certainly an area that needs more investigation, but fortunately, we have better options. So what do we have for RET? We learned early on that RET is a target for several multi-kinase inhibitors. If we look at these kinome trees of drugs like lenvatinib, sunitinib, we think of these as anti-angiogenic TKIs, but they target many molecules, many kinases, including RET, which is right up here, and some of the drugs off the shelf, like cabozantinib, vandetanib, they did have activity at RET. Now, this is a time when we were desperate for something that worked. The response rates you can see on this table are pretty poor, about 20-30%. And for anyone who's used these drugs, either for RET-positive cancers or kidney cancer or thyroid cancer, these are very challenging drugs to give. When we think of targeted therapy, it brings out certain connotations, and this doesn't feel like targeted therapy. When we think of targeted therapy, we think of a biomarker where someone comes in, you get excited to give a drug, you're confident the drug is going to work for almost everyone. It may not work for everyone, but it's going to work quickly, it's going to be well tolerated, and in your head, you're picturing a certain type of waterfall plot. And that's what this drug is, selpercatinib. And the RET-1001, this looked at selective RET inhibitor. If you look at that kinome tree on the right, much more selective here, a smarter drug. Our medicinal chemists design better drugs. And we see in people with prior chemotherapy, response rate here is 61%. Compare that to 15-30% with older drugs. Complete response, 7%. Duration of response, over 2 years. Durable responses that are very quick. And when we start with a drug like selpercatinib, response rate of 84%. That is exciting. Complete response, 6%. Duration of response, 20 months. These drugs work well in the brain. In the RET-001, 26 patients had measurable brain mets. The intracranial response rate, 85%. This is what we want from targeted therapy. Now, there certainly are toxicities. If you look at the most common grade 3 toxicity, hypertension, that's because on that kinome tree on the right, RET and VEGF are pretty close to each other. But if you look at the dose reduction rate of 30%, it only translated to discontinuation of 2%. So tolerability is a subjective word. Very few people had to stop this drug because of side effects. That's what we want. This was FDA approved May 11, 2020. And right in its heels was another selective RET inhibitor, pralsetinib. This was in the ARROW trial. And patients with prior chemotherapy, we see again this shape of the waterfall plot, response rate 59%. Responses are quick. Generally, the first scan, you're going to see a response, and they're durable. And it works even better in the frontline setting. There's no question we should be reaching for these drugs first as soon as we see that RET fusion. This drug also works well in the brain. Response rate here is 70%. And in patients without brain metastases, CNS progression is only seen in 2 patients. and so some CNS protection. It sort of keeps that area protected. Dose reduction rate 38%, discontinuation rate 6%. You do see more myelosuppression with pralsetinib. It's because if you look at that kinome tree on the right, we have a little bit of activity at JAK1, JAK2, so there is some myelosuppression. Important to watch neutrophils, lymphocytes, but overall, a well-tolerated drug, FDA approved September 2020. There are other selective RET inhibitors under study, BOS 172738, SY5007. This is a drug being developed in China. Give you that similar feel. These would not be next-gen RET TKIs, but just more selective RET inhibitors, and certainly the more the merrier. Hopefully this gives more cost-effective options in the future. But there are some rare side effects with these agents. Hypersensitivity reactions, we're seeing a little bit more. I just had one not too long ago. Rash, fever, arthralgias, myalgias. People start to feel pretty sick. Drop in platelets, LFTs go up. Rarely, in severe cases, hypotension, tachycardia, creatinine goes up. You see a very diffuse rash. This is typically with selpercatinib, not so much with pralsetinib. You stop the drug, you give steroids, you can re-challenge, but at a lower dose. And when we look closely at who's getting this, it's primarily people that have immunotherapy first. Just like we see with EGFR and ALK. When we see a driver, you got to use targeted therapy first. And when we give a checkpoint inhibitor, we change the toxicity of everything that follows. And so it's best to use these drugs first. That means we've got to test early, and we've got to reach for targeted therapy before we expose patients to immunotherapy. Chylothorax and chylosocites, this can be seen in about 7% of patients with selpercatinib, not seen in pralsetinib in this series, which Dr. Lin was part of, happened anywhere from half month to 50 months later. And it doesn't mean you have to stop treatment. This is an important toxicity. It's unusual, but it's important if you see someone that you think is progressing on the drug because of a pleural effusion, because of ascites, you want to do a thoracentesis, you want to tap that because it might be a drug toxicity. They could respond to dose reduction or switching to another TKI. Doesn't necessarily mean they've been progressing. So you don't want to deprive somebody of a drug that's working. Should we use them in the front line? I think certainly based on the response rate and toxicity, yes, but we do have a phase 3 trial here, Libretto 431. It's a randomized phase 3 trial for patients with RET fusion positive lung cancer, randomized to standard chemotherapy with or without pembrolizumab versus selpercatinib with optional crossover afterwards. And what we saw was selpercatinib was superior, a higher response rate, more durable responses, 2 years versus 1 year. The PFS, 24 months versus 11 months. It's a hazard ratio of 0.46, a clear win. What we also noticed in this study, in the control arm, patients could receive immunotherapy, didn't have to, and those curves didn't really look too different. Pembrolizumab not really adding things when it comes to RET-positive cancer, something we would have suspected, but it's really nice to have that data. And should we move these even earlier? As we heard this morning in EGFR and ALK, we use these after surgery. Is there a role for adjuvant selpercatinib? Libretto 432 will look at selpercatinib for 3 years after surgery. And so we'll see what the results there. But like with all targeted therapies, we do expect resistance. So what are we learning about resistance? Here's a series led by Dr. Lin, resistance to selective RET inhibitors. We see on-target resistance, as we'd expect, like RET G810X. This is a setting where new selective RET inhibitors might be effective, but also off-target resistance, usually in that MAP kinase pathway, MET, KRAS, EGFR amplification mutations. We're seeing different mechanisms, as we've seen, again, following the paradigms and applying everything we've learned from ALK that Dr. Lin just went over. You also do see histologic transformation. You suspected it would happen with all targets. We do see it with RET. It's uncommon, but probably underdiagnosed. Here's a case of adenocarcinoma with a KIF-RET mutation. They received pralsetinib, small cell transformation. The RET fusion is still there, as shown by the fish on the right, but clearly the biology is quite different at this point. New RET inhibitors, well, we wish there were more. A lot of those programs have unfortunately closed. One that is still moving forward is EP0031. In the US, this is 3-Lipsis. In Asia, it's KL590586. But this is a next generation RET inhibitor. And here in patients that have already had a selective RET inhibitor, response rate of pretty respectable 36%, disease control rate 71%. They did see CNS responses, complete responses in 3 out of 4. So early days, but there are new RET inhibitors coming. And so hopefully we'll be able to see multiple lines of therapy in RET as well. And just to close on RET, we can also see RET on the other side of things, RET mediating resistance, acquired RET fusions. Here in the setting of EGFR mutant lung cancer treated with osimertinib, we saw RET fusions at resistance that we were able to successfully target On the left with selpercatinib, that's a case from Zofia Piotrowska, and on the right from pralsetinib, that's one of our patients at Georgetown. These drugs can work. My experience is they don't work for too long, but we can certainly get responses in that setting. So the other subtype that we'll talk about is ROS1, again, about 1%. What's interesting about ROS1 is there's about a 75% homology with ALK. So a lot of ALK inhibitors that we just learned about are also ROS inhibitors, but not all ALK inhibitors are ROS inhibitors. And so when we think of alectinib as a good ALK inhibitor, almost no activity at ROS1, so they're not interchangeable. Also a high incidence of brain metastases here. The first drug approved was crizotinib based on that very impactful Profile 1001 study. Response rate 72%. You do see complete responses. They're quick, they're durable. And again, we should be able to draw these waterfall plots before we even start the study. This is going to work in most patients. We saw PFS here of 19 months. There were toxicities, but primarily low-grade visual and GI toxicities, no grade 4 or 5 adverse events, no discontinuations. FDA approved 2016. The second drug approved here was entrectinib, based on the ALKA and the Star Trek studies. A lot of people in this room participated in these trials. We saw high response rates. We saw durable responses here, 2 years, intracranial responses. The difference here between these drugs, even though the PFS in these studies are the same, they were done in different eras. And we do think that entrectinib probably a better drug in the brain. These were the two drugs for a very long time. Entrectinib, though, has different toxicities, weight gain. You're seeing more dose reductions. But this was approved by the FDA in 2019. And most recently, repotrectinib, based on the Trident study. Response rate in the frontline setting, 79%. After prior ROS1 inhibitors, 38%. But if we have a known resistance mutation like G2032R, response rate was about 60%. When we look at these toxicities, though, we're seeing a lot more interruptions, a lot more dose reductions. This was approved over a year ago. But the reason that we're seeing different tox profiles is really different ways the drugs are designed. Repotrectinib and entrectinib are both also NTRK inhibitors, which we'll hear about next. And as we know, when we target NTRK, there are consequences to targeting NTRK. And we can see hyperphagia, we can see loss of proprioception, we can see nociception changes, and this leads to more toxicity. If you have an NTRK-positive cancer, that's good, but when you're targeting ROS1, that's really just more cost with no benefit. Lorlatinib does have activity in ROS1. It'll be listed in the NCCN guidelines. It is not FDA approved, but it is an active drug here. But the newer agents seem to hold a lot more promise. Taletrectinib, response rate 91%. After crizotinib, 52%. These are highly effective drugs. And because this is more selective against TRK, we're seeing less toxicity, lower discontinuation rates. And of course, zidesamtinib or NVL-520. This is a potent CNS-active selective ROS inhibitor. So in theory, should not have any activity at TRK. We're seeing activity in a heavily pretreated population. A very exciting update here from Benjamin Bess. Durable responses. We haven't reached the median. We're seeing intracranial efficacy. If you could give a ROS1 selective inhibitor with no activity of NTRK, you could push the dose, get CNS responses, get durable responses, and hopefully, importantly, a lot less toxicity. And that's what we're seeing. The dose reduction rate here, 8%. There were no drug-related AEs that led to drug discontinuation. Remarkable safety in these drugs. And this is just where the field is going. We're getting smarter with drug design. Our drugs are getting better, and our patients will benefit from those. Another note about both RET and ROS1, you can also see MATE1 inhibition. This will lead to a rise in creatinine, but that is not due to kidney failure. It really is just retention of creatinine itself. If you were to look at a surrogate like cystatin C, you'll see the GFR is actually the same. So important to note this is not necessarily a dangerous toxicity. And lastly, these are wonderful drugs, tremendous opportunities here, but these are only impactful if we find the mutations and fusions when they're there. This is a series out of Memorial Sloan Kettering for patients that had next-gen sequencing with DNA-based tests. And if they had no drivers on DNA, all they did was RNA-seq. 13% of the time, they found something that was actionable, including, most commonly, ROS1. So if you're only doing DNA-based NGS, you are going to miss some fusions. And the question is, how many is okay to miss? We really think RNA is something that needs to be incorporated more. But even before that, our testing rates here in the US, the Mind Lung Consortium looked at patients with insurance, with access to testing, access to drugs, and we saw that for RET, we're only testing 2/3. For ROS1, only 75%. So there are a lot of patients that are not being tested. If we're not testing these patients, we are giving them the wrong treatment. And so certainly we need to look inside and make sure we're getting 100% testing rates. When they're there, we have to find them because they make a difference, and we don't want to deprive our patients of these opportunities. These selective inhibitors really should be used in the frontline setting for both ROS1 and RET. Resistance is something that's still unfolding. We need better drugs, and we're getting better drugs, but certainly the future is bright for both of these targets.
Thanks a lot.